Hello, my name's Roger Henderson. I'm a GP in Scotland and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us on all major podcast platforms, so do please follow us to receive notifications about new episodes. And if you like what you hear, do please consider leaving a review to help other listeners find us. It really does help. Now in this episode, I'm going to be discussing keloid scars, a unique and complex dermatological phenomenon characterized by the overgrowth of dense, fibrous tissue that extends beyond the original boundaries of a wound. Now, unlike normal scars that gradually fade and flatten over time, keloids unfortunately tend to grow relentlessly, often becoming larger and more prominent than the initial injury site. But first of all, though, a little bit of history, because keloids have been documented for thousands of years, with references dating as far back to ancient Egyptian papyri. The term keloidy was coined by Baron Jean-Louis Albert in the early 19th century, and it was derived from the Greek word kele, meaning crab's claw, signifying the invasive and claw-like extensions of these scars into otherwise normally unaffected skin. Now, over the centuries, the understanding of keloids has evolved considerably, although many aspects of their pathogenesis do still remain unclear. The prevalence of keloid scarring does appear to vary widely among different populations and is heavily influenced by both skin type and genetic predisposition. And keloids have always been thought to be significantly more common in people with darker skin tones, particularly those of African, Hispanic and Asian descent. But this has become a slightly disputed view in recent years, although keloids do appear to be most common amongst Afro-Caribbean people, with an estimated incidence of around 5 to 10%. Both sexes are affected equally, and although keloids can theoretically occur at any age, and I have seen them myself in elderly people, they are most commonly seen in adolescents and young adults, coinciding with periods of heightened collagen production. Hormones may also play a part, given the observation that keloid scars often develop or worsen at puberty and during pregnancy, and there's often a slight improvement following the menopause. So, at its most basic here, keloid formation is a disorder of wound healing and usually develops in response to inflammation or trauma to the dermis. Now, normally wound healing proceeds through a highly regulated process involving hemostasis, inflammation, proliferation and remodeling. But in keloid pathogenesis, there's a dysregulation of these processes, particularly in the proliferation and remodeling phases. If we look at the fibroblasts in keloid scars, these do exhibit abnormal behavior, including excessive proliferation and heightened production of extracellular matrix components, especially type 1 and type 3 collagen. Moreover, the balance between collagen synthesis and degradation is disrupted, and multiple factors appear to contribute to the sustained angiogenesis, fibroblast activation, and the extracellular matrix deposition that are seen in keloids. Now, clinically, as we all know, keloids present as firm, raised, shiny nodules or plaques that often extend beyond the margins of the original wound. Now, the type and location of any skin injury does influence the risk of keloids. So, high tension areas, and I'm thinking about the chest, upper back, shoulders, and even the cheeks, are particularly prone to keloid developments as well as earlobes. The common precipitating injuries for keloids include things like surgical incisions, ear piercings, lacerations, burns, acne lesions, and even minor abrasions. Infections, foreign body reactions, and delayed wound healing can all further increase the likelihood of a keloid to form. Now, some may develop rapidly within weeks of any skin injury, whilst others may evolve over months or even years. And unlike hypertrophic scars, which may regress over time, keloids unfortunately rarely resolve spontaneously and often persist indefinitely. The colour of keloids varies from pink to red to dark brown, and this frequently depends on the individual's skin type. During their active growth phase, keloids may be erythematous, but as their growth then slows, the keloid may slowly become similar in colour to the surrounding skin. The surface of the scar is typically smooth and shiny with an overhanging edge, and most tend to be firm in consistency. And it's worth mentioning there are no hair follicles or sweat glands within a keloid scar. They're often asymptomatic, but they can on occasion be associated with symptoms such as pruritus, pain, burning, or tenderness. And in some cases, they can even cause functional impairment, particularly when they occur over joints or other areas of significant movement. Now, in addition to any physical discomfort, keloids often have a profound psychological effect, leading to decreased self-esteem, social withdrawal, and in severe cases, even a full clinical depression. Now, distinguishing keloids from hypertrophic scars is essential for their appropriate management. So hypertrophic scars, unlike keloids, do remain confined to the borders of the original wound and often show signs of gradual regression over time. Histologically, hypertrophic scars display more organized collagen bundles and a higher density of myofibroblasts, which does contribute to the contractile nature of these scars. I think it's worth mentioning other conditions that can mimic keloids, and these include things like dermatofibromas, hypertrophic lichen planus, cutaneous fibrous histiocytoma, and even cutaneous neoplasms. Accurate diagnosis, therefore, typically relies on clinical history, physical examination, and when necessary, a histopathological evaluation. But the diagnosis of keloid scarring is always primarily a clinical one, and a skin biopsy is rarely required. If a biopsy is considered, this has to be weighed against the risk of making the condition worse, and the usual reason to perform a skin biopsy here is when there's any doubt about the nature of the lesion or if there's a clinical suspicion of an underlying malignancy. Now, as we all know in our practices, the management of keloid scars is notably challenging, with high rates of recurrence even after treatment, and unfortunately, the existing evidence to support an ideal treatment of keloids is still weak. A multimodal approach often does yield the best outcomes, and this combines surgical, pharmacological, and physical therapies tailored to the individual patient. So in general, single small keloid scars can be treated non-surgically, whereas large, bulky, or multiple keloids should always be assessed for surgery and adjuvant therapy. Now, intralesional corticosteroid injections, particularly triamcinolone acetonide, are a mainstay of treatment, and these aim to work by reducing inflammation, fibroblast proliferation, and collagen synthesis. These injections are typically given every 3 to 4 weeks, and they may lead to partial flattening and relief of any symptoms. But recurrence after cessation of therapy is common, and despite the popularity of these injections for the treatments of both keloids and hypertrophic scars, there does remain little conclusive evidence to support any definitive treatment protocol here. Possible side effects of these include pigment changes, telangiectasias, and subcutaneous atrophy, which may actually resolve. Some skin specialists also believe that steroid-impregnated tape that's applied for 12 hours a day may flatten keloids in some cases. The surgical excision of keloids, when performed in isolation, carries a very high recurrence rate, often exceeding 50%, and the resulting scar may be actually larger than the original keloid. And so surgery is usually combined with adjuvant therapies such as corticosteroid injections, radiotherapy, or pressure therapies to reduce the likelihood of any recurrence. Talking of radiotherapy, if this is applied post-operatively, this can effectively decrease fibroblast activity and prevent keloid regrowth in some people. Now, low-dose superficial radiotherapy is generally preferred here to minimize adverse effects. And although there have been some concerns about its potential carcinogenic properties, providing the surrounding tissues are protected, this risk does appear to be very low. Silicone gel sheeting and pressure therapies are non-invasive options that may also be employed as first-line treatments or as adjuncts to other modalities. Now, these therapies help to hydrate the scar, to modulate collagen synthesis, and in the case of pressure therapy, mechanically reduce any tissue tension. Their efficacy is variable, I'd say. The evidence is weak, and patient compliance is absolutely crucial for success. However, I have found that compression earrings used after the excision of earlobe keloids do appear to have a good rate of recurrence-free healing, but you have to wear these 24 hours a day. Cryotherapy involves the application of liquid nitrogen to induce a freeze-thaw cycle that then induces cell death and causes scar regression. And this is often used for smaller keloids to prevent further growth, and it can be combined with intralesional corticosteroids to enhance any treatment response. However, we must remember that cryotherapy can cause hypopigmentation, particularly in individuals with darker skin, and there may also be a degree of discomfort and even prolonged healing. Now, laser therapies are increasingly popular, particularly pulsed dye laser and fractional CO2 lasers, as these can improve the colour and texture of keloid scars. In general, flatter keloids are more suitable for laser therapy because the beam can reach an adequate depth of penetration. And laser treatment may also reduce vascularity and fibroblast activity, although recurrence still remains a concern. If we look at emerging treatments, these include intralesional injections of chemotherapeutic agents such as 5-fluorouracil and bleomycin, which can inhibit fibroblast proliferation. Now, the clinical effectiveness of intralesional fluorouracil does seem to be similar to corticosteroids, with recurrence rates of up to 47%. And according to one meta-analysis, intralesional bleomycin significantly improves both keloid and hypertrophic scarring compared with triamcinolone, fluorouracil, and cryotherapy plus triamcinolone. Ongoing studies are also investigating the potential of imiquimod, interferon therapy, and botulinum toxin as adjunctive or primary targeted treatments for keloids. Gene therapy and molecular treatments aimed at modulating fibrogenic pathways do represent promising areas of future research, and it's to be hoped that advances in the understanding of genetic and molecular underpinnings of keloid formation may eventually lead to more effective and personalised therapeutic options. As a final point in my experience of patients with keloids, I think it's absolutely vital to remember that beyond their physical manifestations, keloid scars can profoundly affect a patient's quality of life. The disfigurement that's associated with large or prominently located keloids can lead to significant emotional distress, social isolation, and even depression and anxiety. And I think it's crucial for us as GPs to adopt a holistic approach to the care of any patient with keloids, addressing not only the physical aspects of their keloid management, but also their psychological well-being. Patient education, psychosocial support, and, if appropriate, referral to mental health professionals should be integral components of any treatment plan. And don't forget too that cosmetic camouflage techniques, including makeup and clothing adjustments, can also help improve self-esteem and social confidence. So that's an overview of keloid scarring, and I do hope you found it helpful for the next time you see a patient with this problem. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you've any questions, comments or ideas for future podcasts. We really do love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur year-round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.